Is this my cue, Carrie? Would you like me to get started?
Yeah, go for it.
Okay. On behalf of United Cerebral Palsy, I'd like to welcome everyone this evening to our professional learning series. Just a few housekeeping things before I introduce our presenter tonight. The meeting is being recorded. We will not be taking questions during the presentation, but you can post your questions by clicking the Q&A icon on the bottom of your toolbar. And there will be a live Q&A at the end of the presentation today. Those that are eligible for CME and credit will receive an email after tonight's presentation. So with that, I am going to introduce our presenter tonight is Dr. Bhooma. I'm going to do this with success, hopefully, Aravamuthan. She is an assistant professor, pediatric movement disorder specialist, a neuroscientist in the Division of Pediatric Neurology at Washington University School of Medicine and the Cerebral Palsy Center at St. Louis Children's Hospital. She completed her research doctorate at the University of Oxford in England, medical school and pediatrics residency at Washington University in St. Louis, and child neurology and movement disorders fellowship at Boston Children's Hospital and Massachusetts General Hospital before returning to Washington University as faculty. Her translational research on dystonia pathophysiology following neonatal brain injury is funded by the National Institute of Neurological Disorders and Stroke and has received awards on multiple organizations, including the 2022 AAN Jon Stolk Award in Movement Disorders Research. Bhooma is a member of the UCP Research Committee. And with that, I welcome you to tonight's presentation on dystonia and cerebral palsy.
Thanks, Tara, for that intro. Let me see if I can start sharing. It's can the person who's currently sharing stop? Perfect. Thank you. Okay. I think everybody can see my presenter view. Let me know if there are any issues. Okay. Oh, perfect. Good. Thanks, Carrie. So I was asked to speak today about dystonia and CP, which is, just professionally something I have grown to love talking about. I think it's a really important topic, and it's just such an honor to be talking about that with this audience today. These are my disclosures, none relevant to the talk today. I want to start out by talking about how in my lab and what we're hoping broadly, how to think about prioritizing the gaps and research needs in this field, thinking about dystonia and CP. Through the Cerebral Palsy Research Network, a few of the people on the UCP Research Committee actually got together with other clinicians and community members, people who were directly affected by CP and their caregivers, to come up with a priority list of research ideas in this field, in dystonia and cerebral palsy. And we came up with the top 10 list. I'm going to show you the top 5. And of these top 5 today, I'll be talking about the middle 3. And I feel like in terms of next steps, what to look out for in the upcoming few years, I think we're going to be making a lot of headway in these 3 priorities. So I'll be talking about some of our work, some of the work I've been honored to be a part of in these 3 topics today. First, I'll talk about improving diagnosis and severity assessments. So what is dystonia? Dystonia, formally defined, is voluntary movement-triggered overflow muscle activation. So what does that mean? So when I talk to my families, I will describe dystonia as Every time you try to make a movement, every time you try to move, a part of your body that you don't want to move moves out of your control. So if you think about dystonia in that context, it is by definition functionally debilitating. So thinking about diagnosing it is incredibly important, because by definition, you're diagnosing something that very likely is limiting that person's function. Dystonia is also arousal dependent. So it tends to go away in sleep, and it tends to be activated by heightened emotion. So that includes stress, but it also includes excitement. So you can see dystonia act up kind of at either end of the spectrum. Dystonia overall is one of the most commonly cited causes of pain in people with cerebral palsy. It's in one study at least cited second only to hip subluxation as a cause of pain in people with CP. So thinking about that, the degree of pain that dystonia can cause, it's important, and I think often under-recognized. Dystonia, as I mentioned already, is inherently associated with functional limitations. People who have greater gross motor functional limitations, so people at GMFCS levels 4 and 5, tend to have more dystonia, and vice versa. If you have more dystonia, you tend to have greater gross motor functional limitations. So really thinking about, if we treat dystonia, can we limit those functional limitations? That's really important. As I'll talk about a little bit later, treatments for dystonia and the evidence we have to support current treatments for dystonia are really limited. And because of that, it's a little bit of trial and error in the clinic in terms of deciding what we're going to use to treat someone with dystonia and CP. And so we have a lot of room to improve there. And that's particularly important in CP because contrary, in some cases, to popular belief, the majority of people with cerebral palsy have dystonia. So if you think about numbers that are typically cited, many people will say that 15% of people with CP have dystonic CP. And that is true in the context of, is dystonia your predominant motor form? Is it the predominant movement disorder that you experience as a person with CP? And if you look at it that way, yes, it is 15%. But if you look at all comers, people with mixed spasticity and dystonia, that's somewhere between 75 to 80% of people with CP have some degree of dystonia. The majority of people with CP have some degree of dystonia. And if you look at it that way, CP is by far the most common condition associated with dystonia, at least in young people. So it is an under-recognized condition associated with dystonia, and dystonia is under-recognized in CP. So it's important to really focus on dystonia in this population. And what I really want to talk about first is, before we can even think about treatments, before we can think about rehabilitation strategies for dystonia in people with CP, we have to first identify that they have dystonia. And that has been a bit of a struggle. And there is room for improvement, and we are improving, but it is a very important first step. Some examples of kind of the gap here, if you look at people, young children, so children less than 5, who are at high risk for CP. So these are kids that were born at term and met criteria for therapeutic hypothermia. So meaning they were cooled as babies, they were thought to have some degree of term hypoxic ischemic encephalopathy, some degree of brain injury at the time of birth. These are all kids that are at high risk for cerebral palsy. And I lay this out because if you take even that population of people and you follow them up in a tertiary care center with experts that should be used to diagnosing cerebral palsy and recognizing the motor phenotypes that you see in someone with cerebral palsy, still in that population, only 30% of those kids have their tone types clearly identified by the time they're 5. So there's a lot of room, particularly early, to even mention the word dystonia to families and even recognize that it could be a part of the tone types that someone is experiencing if you think they might have CP. But that's young children, and we would, many clinicians agree that it is particularly difficult to diagnose dystonia in young people. But even if you take older people, so this is a group of people that were aged 10 to 20 years old, that we videotaped in our clinic, people that we see in our clinic, we videotaped walking down a hall. And when we assessed those videos in consensus, so a group of experts viewed those videos, we were able to say that these people demonstrated dystonia during their walking, and these people did not. These people had leg dystonia, these people did not. When we went back to the clinic notes that were written on the same day, only 13% of the people that we know definitively had leg dystonia based on expert consensus review of those videos. Only 13% had any mention of dystonia in their clinic note on the same day. So there is a huge rate of underdiagnosis of dystonia clinically, even in some of the best centers in the country. So what are ways that we can improve this? So again, through the CPRN, we launched a quality improvement initiative for clinicians. And these are all people that are already very committed to wanting to improve their ability to diagnose dystonia accurately and appropriately during clinical care. And the way we were currently doing it was not consistent. So we were writing it down. We were saying someone had dystonia if we saw it, but we weren't necessarily screening for dystonia in the same way every single visit. So we established a set of criteria that we wanted clinicians to use. And these are written down here, both in terms of history, so things that we asked the families, we asked them about variable tone, things that we assessed on the exam, and just at bare minimum, did we say the word dystonia at all? That either it was present or absent? Did we even say the word dystonia in the note? And we tried to make sure that we established a consistent way to do this in every single one of our visits. So this is an example. This is just what one of our notes looks like at my center in St. Louis, and how we make sure that we're checking, all of these important features to make sure that we're consistently considering dystonia diagnoses at every visit. And when we tried to do this across multiple sites, obviously it took some time, but in about a year and a half, we got to the point where at least these three sites in the group of physicians for whom we rolled this out, that almost all of our visits, we were using this sort of smart phrase, so this sort of structure to be able to document dystonia, the presence or absence of dystonia in our clinical visits. So that's great. So we changed our practice, but did it actually change anything for the families? Did it change how we diagnosed anything? And it turns out that it did. So starting out in our clinic, our dystonia diagnosis rate across all three centers was about 52%. Now, keep in mind that we think somewhere up to 75 to 80% of people with CP at large have dystonia. Our dystonia diagnosis rate was only at 52%. After we instituted the SMART phrase, our dystonia diagnosis rate increased to 69% in the centers that were, after we started using the SMART phrase, in the centers that use the SMART phrase. So we think really just by increasing awareness and developing a consistent method to start screening for dystonia, we're actually improving the rate of dystonia diagnosis. And we're hoping that efforts like this, if we are able to get uptake more broadly and put out ways to do this more easily in your clinical workflow, that it'll actually increase rates of dystonia diagnosis in the CP community and actually get people access to the current treatments that exist. Step one is always getting the diagnosis. It's awareness that dystonia exists at all before we can even approach treatment. As I mentioned earlier, there's a gold standard concept for dystonia diagnosis, and that's expert consensus. So that's a group of people, movement disorders physicians or dystonia experts in some fashion, a group of people in a room that are maybe evaluating a person with cerebral palsy together in the clinic, or are reviewing a video of that person walking or doing a motor task together. And then they all discuss and they say, okay, together I think this person does or does not have dystonia in these locations. But that is a very time-consuming process, and it requires multiple people to be collaborating in the care of a single person, to be viewing a single video or to be examining a single person. And that's not typical clinical practice, right? Typical clinical practice is you see one person in clinic for somewhere between 20 to 30 minutes in a follow-up visit. How are you going to generalize what the gold standard dystonia diagnosis is to an individual short clinic visit to practitioners, across the country, if not the world? How do we make this gold standard more accessible? So what we did was we tried to analyze in these consensus discussions, what is it that experts are saying? What are they actually describing in these videos that makes them say someone has dystonia? So we started out with videos of people walking, people's cerebral palsy as they were walking. They walked 15 feet in a straight line to the camera. All of the people that we videoed for assessment by 3 experts also had spasticity. And we felt this was really important because we wanted to make sure that when they described the features that they thought were dystonic, that they were distinguishing them very clearly from the features that were spastic. So it was very important to us that both of these types of tone were present in the same person at the same time. We had them all grade dystonia using a 10-point scale. And for this particular project, we only had them look at the legs. So these are 2 example videos of young people in our clinic. And this is a bit of a dramatic example, I will say, but the first person here is walking in a straight line, pretty consistent speed, pretty consistent pace, step width, step length, all very consistent, repeatable. Now, this person does have some gastrocnemius spasticity. It's a tiny bit of a toe walker, but overall gait is very consistent. This person, you'll see as they're walking, has a lot of variable gait. So crossing of the leg one way or another, there's a part where their foot turns in, and there isn't really a consistent speed or direction or step width or length that we're seeing for this person. When we asked experts to describe what it was about a video that made them decide someone did or did not have dystonia, and I'm sorry to clarify here, the person on the left here, experts said did not have dystonia, and the person on the right here, experts did. So their average score here was greater than 1, suggested that this person did have dystonia, and their average score here was 0, saying that this person did not have dystonia. And when we asked them to describe why, they kept mentioning things like consistency when saying that there was no dystonia or lack of variability. And when they mentioned that there was dystonia, they mentioned things like variable and adduction, scissoring, so bringing the legs in, bringing the feet in. And they also mentioned that it seemed to limit function. So that sort of variability in the gait seemed to limit their functional ability. What we then did was we took all of the statements that they made during those consensus building discussions, and we broke them down into individual ideas. And then we counted the number of times those ideas showed up in conversation as they were trying to establish whether a person in a video had leg dystonia or not. And here you see on the left a frequency distribution. So the most common things people said here are on the left, the least common things here are on the right. On this graph here on the left is features that experts use to justify the presence of dystonia. So these are things that the experts said when they were saying, yes, there is dystonia. And here on the right, these are things the experts said when they were saying, no, there is not dystonia. And something that they really harped on was this concept of variability. Lack of variability suggesting no dystonia, and presence of variability suggesting yes dystonia. We then looked at the features experts use to talk about dystonia severity. So what made someone's dystonia more severe than another person's dystonia? And there were 2 features that they cited, the experts cited most frequently: effect on gait, namely gait variability, and effect on adduction amplitude. So gait variability effect is here in blue. The darker the color blue, the more severe that person's dystonia was eventually rated. And you see that the gait being affected, so that sort of gait variability, that increases in frequency with increasing dystonia severity. And gait being unaffected or gait being consistent, that decreases in frequency as the dystonia severity increases. So really suggesting, again, that gait variability, gait being affected is an important feature. In addition, looking at amplitude, in the least severe dystonia, so again, lighter colors are less severe dystonia, you see the least severe dystonia, the experts cited small adduction amplitude, so small scissoring or leg crossing or a little bit of foot turning inwards. But with more severe dystonia, you see there's an increased frequency of people saying that there's large adduction amplitude. So again, suggesting that this adduction and the amplitude of adduction is really critical for experts to be able to identify dystonia and distinguish it from spasticity in these people. So if we're to summarize that, we talked about variability, we talked about function, effect on gait, and then we talked about adduction amplitude. So how big was that movement in of the legs and the feet? When we take all of these things together, so now we know that these are expert-cited features, we can let other clinicians know, hey, these are expert-cited features of dystonia. Watch out for that when you see people with CP walk in your clinic. Look for these features if you're trying to diagnose dystonia. So that is, we think, inherently valuable. But these features were all picked up on just regular smartphone videos you can take in a clinic, and they're inherently quantifiable. So can we actually calculate the features that experts are picking up qualitatively? Can we quantify them? So what we did was we used an emerging set of something called pose estimation software that's come out in the last few years to be able to label different body parts on just these smartphone videos that we take in the clinic. And then we use that to calculate features that align with adduction variability and adduction amplitude in the legs, to see if that correlated with expert assessments of dystonia severity. And when we did that, after we were able to label the knees, ankles, and toes reliably on these videos and look at adduction amplitude and variability, we saw that both of these features tracked really nicely with expert assessments of dystonia severity. So here on the x-axis, the higher the number on the x-axis of both of these graphs down here, the higher the number, the more severe someone's dystonia was rated by an expert in their legs. And here on the y-axis, this is foot angle minimum. So the lower the number here, the more adducted someone's feet were, the more they came in. And here, the higher the number, the more variable that adduction was. So you can see with greater severity expert ratings of dystonia, there is greater adduction amplitude. And then on the right, you can see with greater severity expert ratings of dystonia, there's also greater adduction variability. So we feel that features like this, when quantifiable, can actually be used to develop sort of automated models to help with dystonia diagnosis in the clinic and point out, hey, this person, you should really look at them closer because we think they're at high risk of actually having a dystonia diagnosis. So that was all done in people walking, but not everybody with cerebral palsy is an independent walker. So are there ways to assess for leg dystonia severity during other tasks that don't require someone to walk? So we looked at really the same features in a task, a hand open close task. So this is a person who's opening and closing their hands on both sides. And then if you look at what's happening to their legs when they're opening and closing their hands, so there is one, and then as they open and close their other hand, you see their legs come in and their feet come in. This is an example of dystonia. This is an example of leg dystonia. When they're trying to move one part of their body, so opening and closing their hand, a different part of their body that they don't intend to move, their legs, are moving out of their control. So this is an example of leg dystonia, and it is really characterized by that leg adduction variability and amplitude that we saw in those walking videos. I will show you this young man next. So he's opening and closing his hand, and he doesn't have a lot of leg dystonia, but you see that he has a different kind of overflow. So he's opening and closing one hand, and you see that the other hand is opening and closing too, kind of at the same speed. And the person who's asking him, these are videos that were shared with us from Gillette as a part of this research study. As he's opening and closing one hand, you see that the other hand is opening and closing as well. So this is different from dystonia. It's a different kind of overflow. This is called a mirror movement. So dystonia, if you're opening and closing one hand, the other hand or another leg or a leg or a different part of the body may twist or change or go into a movement, but that movement should not mirror the initial movement. So if someone is doing this, doing a fast open and hand open and close of one hand, and the other hand is doing the same thing, that is mirroring, and that's not dystonia. If the other hand is doing a different movement that the person is not intending it to do, that very well could be dystonia. This is an important distinction. Mirror movements in very young children are actually developmentally normal, present in typically developing children. They can persist for a longer period of time in people with cerebral palsy. And some of our older kids with CP actually say they use mirroring to their advantage. Sometimes they'll they'll do something with their stronger hand and use the mirroring in their helper hand, so to speak, to be able to use the helper hand to be able to assist a little bit better. Very different phenomenology from dystonia, and it's important to keep in mind to differentiate those two things. This young lady also has dystonia in her legs, but it's very subtle. So I'm going to replay that video again because we may have missed it already. So you see she's opening and closing her hand very slowly, and then as she speeds up, the legs come in. I'll show you one more time. Opening and closing her hand slowly, and then as she speeds up the hand opening and closing, then the legs come in. So the reason I'm pointing this out to you is because it shows perhaps the inherent value in doing some of the quantification that I talked about before. Some of this can be very subtle, and it's very hard to pick up on it in a very short clinic visit. You can't pay attention to everything all the time. So sometimes some of these quantifiable metrics can be helpful to clue you in on things that you may not have caught in the 1 second or 2 seconds that it happened, but could be suggestive of there being underlying dystonia. What we did with these videos was we quantified a lot of the same metrics. So we looked again at adduction amplitude and adduction variability. And what we found in these videos, and let me orient you a little bit to these graphs. So the blue dots here, these are all individuals that have CP that includes spasticity and dystonia. So these are all people that experts identified as having dystonia in their videos. The dots here in gray are people with CP that did not have dystonia as defined by the experts, that only had spasticity. So all of the people represented by these dots had CP and spasticity, but only the people in blue were identified by experts as also having dystonia. So you see that if we look at these graphs that look at adduction amplitude and these graphs that look at adduction variability, that these adduction variability metrics do really seem to be able to separate at least some people, some of these people with spasticity and dystonia from people with spasticity alone, although there is a lot of overlap between these groups. But in terms of where the greatest spread is between the people with spasticity and dystonia and the people with spasticity alone, it's really in this adduction variability metric. We see that at multiple different parts of the body. So here it is at the feet, this is at the knees, this is at the ankles, this is at the toes, and you see that the graphs kind of look very similar across all of these metrics, that these variability metrics really give us more of a spread between the groups, a better ability to discriminate between the groups. Excuse me. When we look at how well these metrics track with expert-assessed dystonia severity, again, the strongest metrics in the seated task end up being adduction variability. So we're looking here at this R² value and how big it is. The closer it is to 1, the stronger the relationship. And you really see here that with greater variability, so with higher scores on this y-axis, you get higher scores on the sex axis. So the higher the expert rated dystonia, the higher the variability. And you see these lines go up, suggesting that relationship. We see it for multiple different markers of variability. So overall in the seated task, it's that leg adduction variability metric that we think can be a quantifiable clue that someone might have leg dystonia. So we encourage people now in clinic to try and use this task as much as possible and to look at the legs at the very least, and hopefully to videotape someone doing the task as well, both so you can track their movement patterns over time and to facilitate some of this quantification to see if that can help you diagnose dystonia as well. We've talked about the legs so far. Dystonia is also present in the arms. It's present in other parts of the body. Let's talk a little bit about features of dystonia in the arms. So let me play this video. This is a young person being examined by Jan Brunstrom, who is the physician who started the CP Center here in St. Louis and one of my mentors. You'll see here that she's also doing this hand open close task. And as she's doing it with one hand, you see the other shoulder turn in and come kind of closer to her body, and you see her hand involvement as well. And you can see how this is very different from the mirroring example I showed you in the earlier video. Her other hand isn't necessarily making the same movement as her first hand. It's an overflow movement that's completely different from the initial hand open close movement that she's doing with her right hand. Here's another young person being examined by Dr. Brunstrom, and you see he's doing a hand open close in one hand, and then in the other hand he's doing hand open close. You saw a little bit of overflow in the legs. You saw his legs raise up, but did you see the dystonia in his other hand? So I'll show you again. So hand open close here. This hand isn't moving very much. Now he's doing hand open close with the other hand. Look at the thumb on his first hand. Look at it spoon up. I'll play it one more time. Opening and closing that first hand, the other hand isn't moving. Now opening and closing the second hand, and look at that thumb again. Look at that thumb kind of curve up. So that's an example of overflow to just the hand. So that is a dystonic movement that's not mirroring because it's not matching the movement that he's doing with one hand, but it is dystonic. It's an overflow. So when we did the same sort of approach here, we tried to quantify the number of ideas, count the number of times experts said certain things to justify whether or not someone had no dystonia, mild dystonia, or moderate severe dystonia. We saw that mild dystonia, so here the lighter colors again are associated with less severe dystonia, darker colors are more severe dystonia. These experts cited the hand involvement more commonly for no dystonia or mild dystonia, but cited shoulder involvement more commonly as dystonia severity increased. So if you're doing a hand open close task and you start seeing movement at the shoulders, that was associated with experts rating that dystonia to be more severe. We also saw the differentiation between dystonia and mirror movement and how experts had really focused on that differentiation when they were making a diagnosis in the mild and no dystonia groups, and how it was important to make that differentiation, because dystonia is something that is something you should focus on treating, and mirror movements is not. We do not typically use medications or other things to treat mirror movements, so it's important to make that distinction. And then the last thing that we really thought was interesting is, I keep showing you all these videos of people doing this hand open close, this alternating hand open close task. We actually looked at a lot of different tasks. We looked at the hand open close task. We had them pick up a little piece of crumpled paper. We had them tap their fingers, finger, nose, finger. And of all of those tasks, the task that was mentioned most frequently by experts to be able to differentiate mild dystonia, so really picking up on the dystonia that may be the most difficult to diagnose, was the hand open close task. And so this is just another reason that we use this task Now, as a matter of course in the clinic, after doing the study, we changed our clinical practice. We always run this task for every one of the kids we see in clinic because we feel that this data supports that it's one of the more sensitive tasks to be able to diagnose dystonia during clinical care. The other thing I mentioned very briefly in our QI work to try and increase our own clinician awareness of dystonia is the history, is asking families, do you see variable tones? And something that I think is really important to recognize is, so far I've talked about, what do experts say and what's the expert consensus and what's the expert gold standard. And I've been talking about that in terms of clinicians, but who really spends the most time either experiencing dystonia personally or caring for someone experiencing dystonia? It's families, it's people with CP and their caregivers. So we sought to see if there were questions that we could ask caregivers and people with CP that really could help us diagnose dystonia based on the history, based on information that families were telling us. And we found in a group of about 100 families that we asked this question, we asked them these questions on a paper survey as they were coming into their clinic appointment. We asked them these two questions. When you try to move one part of your body, do you move another part without meaning to? And during activities, when someone handles a part of your body, do you move a different part of your body without meaning to? And if people in that group, if people answered yes to both of those questions, 92% of the time they had dystonia. So that's pretty great in terms of a diagnostic metric. And it really relies on the expertise inherent in the CP community, the expertise that families have, which is so great because I think we often rely on, we need to train clinicians better, we need to increase clinician awareness. This makes it really important to increase family awareness and to include families as partners in this diagnostic journey. We also saw that if people said no to both of those questions, that there was a pretty high likelihood that they did not have dystonia. So we found it useful for both rule in and rule out on both ends of the spectrum. So again, engaging families as partners in a diagnostic process that we thought was, for a long time segregated to, a group of MDs in a room. It's more than that. It's everybody. It takes a team, and relying on the families in addition to all of the medical providers as a part of that team is really important. So we've talked about diagnostic and severity assessments and our work in trying to improve access to that and improve the quality of those things. To summarize that, in terms of the QI initiative, we want people to be vigilant and to always think about dystonia every visit. Dystonia is inherently variable, so you may not pick up on it in one visit, but you may on the next. So always be aware that dystonia could be there. We talked about history and the importance of involving family. On exam, we talked about using that hand open close task as a really valuable task to trigger dystonia in the clinic and to look for dystonia in the clinic. How variable leg adduction is a great marker of dystonia in the legs during the hand open close task and during walking, and that in the upper extremities, in the arms, that mild dystonia may only really show up in the hand as overflow, and then as you start getting involvement of the more proximal parts of the arm, so the shoulder, that was associated with more severe dystonia rating. Next, I want to talk about rehabilitation and psychological management approaches for dystonia and CP. And I want to start this section by saying this. If there's nothing else you take away from this talk, please let it be this. To manage dystonia, first you have to start by managing its triggers. If the triggers are not managed, you just don't have a chance of treating the dystonia if it's going to keep being triggered by something that you have not addressed at all. And what are common dystonia triggers? So pain is a big one. And it's important to think about various extraneous causes of pain, like hip subluxation, contractures, constipation, reflux. Addressing all of those things is incredibly important. But also there is inherently a potential for pain in all people with CP that might be under-recognized. So neuropathic pain is definitely possible in a lot of people with CP, and dystonia itself is painful. So for people for whom the dystonia is painful and that pain makes you have more dystonia, what a vicious cycle that can be. So thinking about addressing all sources of pain in someone with CP is important. Poor sleep, that is it's a killer for all sorts of things, but dystonia included. As I said earlier, dystonia tends to go away during sleep. And if you're not sleeping at all, you just do not get a reprieve. And that makes a lot of things worse, including dystonia. So addressing sleep is very important. And then, as I said before, heightened mood as well. So dystonia is arousal dependent. So being very excited, but also anxiety in people that have, that are more prone to experiencing stress. That can be a big trigger of dystonia as well. So if we think about, how common are these triggers in people with CP? So if we look at our population in our CP center in St. Louis, and these are numbers taken from about 700 families. The majority have dystonia, so 69% have dystonia, and 17% have dystonia as their predominant tone. So this is kind of in line with the national numbers that I described to you earlier. And then if we look at the frequency of these, these potential triggers, it's pretty high. So somewhere between 25 to 30% of people have pain, poor sleep, and or anxiety as coexisting with their other CP symptoms. So people have a lot of these other triggers. And if we're not addressing them, it's very difficult to treat the underlying motor concerns they may be facing. So when I say dystonia can't be managed without first managing its triggers, this is not like a one-off problem. This is, up to a third of people with CP, this is a big problem. So it's important to make sure that you're addressing those triggers first and foremost. So how should we do that? How do we address those triggers, particularly in the context of CP? So for sure, ask. And then when you've asked about them, are there specific medications for dystonia that kind of give you double coverage that can help with the dystonia and also help address some of these triggers? So this is the AACPDM, American Academy of Cerebral Palsy and Developmental Medicine, care pathway for dystonia and cerebral palsy. And I'm going to highlight just this middle flowchart box here. I will tell you this pathway is currently under revision, so please do expect updates soon, hopefully. But this is the current expert-based consensus recommendations for treatment. And they note that generally you can use baclofen or trihexyphenidyl for treatment, but that for specific indications like painful dystonia, they suggest using gabapentin. And dystonia with poor sleep, they suggest using clonidine and maybe benzodiazepines, maybe another class of medications, but clonidine is suggested first. So there's coverage or mention of dystonia and pain and poor sleep. What should we do in the setting of anxiety? I'll tell you what we do. So in our clinic, we really do screen for this and think about prescribing an SSRI or an SNRI to make sure that we're treating anxiety. We find that to be a significant cause of dystonia. And if there's a lot of mood lability associated in a person that has dystonia, we can think about actually prescribing an antipsychotic agent that could help both the mood lability and also help with some of the movement disorder, some of the dystonia itself. So these are all things we consider sometimes first or second line, honestly, in people that have these coexisting conditions that trigger the dystonia. In addition to focusing on the triggers, including the potential mental health triggers like anxiety, what are some therapy-based, some non-medication options that we can look into to help manage dystonia? And there was a really lovely paper that came out with Hortensia Gimeno, who's a researcher in London. She published this in 2019 in a journal called Neurology, looking at cognitive orientation to daily occupational performance therapy, or co-op. And in this type of therapy, it's very goal-focused. you define a very set functional goal, and then you go through an iterative set of exercises and steps to gradually achieve that goal. So it is effectively retraining the motor circuits that dystonia may have taken over. It's retraining that circuit to be able to relearn how to accomplish a certain functional task. And it is overall remarkably effective for very tightly defined functional goals. So here are some example goals that were described in this paper: eating ice cream and tying a tie. And here is kind of the change towards achieving that goal with time. So higher scores on this axis suggest higher ability to achieve that goal. And you see that the actual intervention period here is in the middle. Here's the baseline. And here's both after the intervention period and then a follow-up. So follow-up, several weeks later, showing that the intervention has long-lasting effects. And something to think about here is the importance of actually setting the goal. So I would hope that many of you are in discussions with your care providers, or for the care providers on the call, that it's a routine part of your practice to come up with very clearly defined functional goals that you're working towards achieving. The Canadian Occupational Performance Measure was used in this study, and it's also becoming increasingly more and more used clinically to help define these functional goals, to help guide both clinical care and then also therapies, one goal at a time. And if this co-op paper is any indication, kind of identifying the goal, achieving the goal, and then moving on to the next goal is a great way of retraining these brain circuits that may be getting influenced by dystonia, to retrain that motor path to be able to accomplish the functional goal that's most important to you. So I think this is a really cool therapeutic approach, non-medication based approach, and it's something that I hope people will consider pursuing if they themselves or someone they care about has dystonia also. Another way of thinking about assessing dystonia clinically is using this newly developed scale, the dyskinetic Cerebral Palsy Functional Impact Scale. This is different from a lot of severity scales that have already been developed, because it's not necessarily based on clinical assessment during a standardized task. It's based on what the family prioritizes and what the person with CP prioritizes as important goals for them in a variety of different domains. And it relies on educating the family and establishing a shared understanding of what that person's dystonia looks like, what dystonia is, and what tasks it's affecting. And it is, I think, a really lovely tool to be able to establish dystonia-focused functional goals to which you can target treatments. So I've been talking about it more and more, and it's something that I'm encouraging a lot of people to look into if you're personally affected by dystonia, and for clinicians to look into to track treatment effects as well. So we've talked about rehabilitation and psychological management approaches. First, and to me, I think this is probably the biggest takeaway from this talk: assess for triggers, treat the triggers first. It is incredibly important to have done that, and to have a chance of being able to reduce dystonia to the point where you're improving functional access and functional ability. And then also try to set focused goals and focus therapies on achieving single goals at a time, both in terms of retraining motor circuits, but also in terms of how are you tailoring all of the other medication, injectable, and other therapies that you're doing at any given time. Let's help families and people with CP achieve a certain goal and then move on to the next goal, as opposed to trying to do everything all at once. Let's be very function focused and goal focused. And that sort of approach has shown efficacy in the studies that I mentioned to you already. Last, I'll talk to you about the effectiveness of current treatments and the data we have on that. So this is a meta-analysis published by Darcy Failing and colleagues that came out a couple of years ago, looking at the available data for existing treatments for dystonia in people with CP. Now, I've started out with the injectables, so botulinum neurotoxin at the top, and then the surgical treatments, intrathecal baclofen and deep brain stimulation. The best data we have really for the treatment of dystonia in people with cerebral palsy is with injectables like botulinum toxin or with surgical treatments like ITB or DBS. There are several studies that suggest that dystonia or motor function and goal achievement can be improved with utilization of these therapies. Most people and the ACPDM pathway would suggest that for focal dystonia, so dystonia that just affects one part of the body, as opposed to generalized dystonia, which may affect multiple different parts of the body, that for focal dystonia, you should go with botulinum toxin preferably over a generalized medication. And then there's an increasing view that if you are, if it's clear that you're having medically refractory dystonia or pharmacologically refractory dystonia, meaning that you've tried a few medications at appropriate dosing and you have been unable to decrease generalized dystonia that is functionally limiting, that intrathecal baclofen and deep brain stimulation are great surgical options to consider. Now, the candidacy for these treatments and who should get ITB and who should get DBS and where should the DBS be placed, I will tell you that is a whole talk unto itself. I'm happy to talk about that more in the Q&A. But what I would like everybody in the audience to know is that these treatments are out there, and if refractory dystonia is something that you are personally experiencing in your family, or if it is something that you are seeing in your patients in clinic, please think about surgical treatment options and think about centers. If your center does not offer them, think about centers that do, and whether your patients or you yourself might be a candidate for those treatments. I just want to make sure that the awareness is there that these treatments exist, and I'm happy to answer more questions about candidacy in the Q&A. That information there, as you might expect, is limited, but I'm happy to talk about our own personal experience at our institution and general experience in the field. Now, if we look outside of injectables and surgical treatments and we focus on medication, the data surprisingly gets more scant. So here you see a listing of 7 different medications on the left here. So there's baclofen, triacylphenidol, benzodiazepines, clonidine, gabapentin, levodopa, medical cannabis. Benzodiazepines being a class of medications like clonazepam and diazepam fall into this category. Right off the bat, 4 of those medications have no data, have no good data for the treatment of dystonia and CP. So if you just look at the 3 medications that were assessed in this meta-analysis, in this pretty comprehensive and extremely well-done meta-analysis, if you just look at the 3 medications that had some data, so that's triacylphenidol, clonidine, and levodopa, only clonidine has decent data supporting that it may actually help dystonia, goal achievement, pain or comfort, or ease of caregiving. Both triacylphenidol and levodopa, the data that's out there suggests that it does not make much of a difference in this population with regards to metrics like motor function or actual reduction of dystonia. Moreover, if we look at the adverse events, some suggestion that trihexyphenidyl, may not change very much, but it definitely comes along with side effects. So these things are important to consider when you think about what the treatment options are that are out there, and when you think about what the treatment recommendations are. The data supporting this is pretty minimal, and the little data that we have, we really only have data to support the use of clonidine for the pharmacologic treatment of dystonia and CP. Now, what does this mean in actual practice? Like, what are people actually doing medication-wise to treat dystonia and CP? This is data that is really fresh for us, and we're hoping to get it out in preprint for broad accessibility soon. But you guys will be the first to hear it. So we surveyed a group of people across the US and Canada, and these were physicians that had membership in the Child Neurology Society or in AACPDM, the American Academy of Cerebral Palsy and Developmental Medicine. And we had a decent response rate. About 50% of these people responded. And we asked them what their dystonia medication prescribing practices were. The majority said that they prescribed medications to treat dystonia if the dystonia was generalized. So very similar to what I said earlier, based on the AACPDM care pathway, that we use medications to treat generalized dystonia and think about Botox more for focal dystonias. And they also only tended to treat dystonia that was functionally limiting. So this makes a lot of sense, right? You don't, just because you recognize dystonia does not mean that you're always going to treat it. But you don't necessarily know when someone's dystonia, so one person's dystonia may not be functionally limiting now, but it may be functionally limiting later. And that functionally limiting status is really what defines whether or not you're going to treat them at all. So it may seem obvious, but it's, I think, an important message to convey. We don't just treat the symptom, you treat based on function. And that's why that goal setting that I mentioned earlier is also incredibly important. When we ask them what medications they use to treat dystonia, you'll see these are the top 6. Baclofan's #1, and the majority of people also use baclofen first line to treat dystonia in people with cerebral palsy. And you'll see that the other medications here are indicated in decreasing frequency. Interestingly, what you don't see up there is clonidine. Now, I mentioned before that clonidine was one of the only medications that had decent data supporting its efficacy for the treatment of dystonia in people with CP. It was used by less than 20%. I think about 19% of respondents used clonidine for the treatment, specifically for the treatment of dystonia. So I tell you this because it is possible that clonidine may be getting underutilized as a dystonia treatment. And if you haven't been on it or it hasn't been considered for you, it may be worth a discussion with your medical provider if you think it may be useful as a potential medication for dystonia treatment. Or as a medical provider yourself, you may think about it perhaps a little bit more as a potential choice for dystonia treatment. But otherwise, overall, across all physicians, these are the 6 meds that were used most often. 80% of the physicians in our survey used a subset of these 6 medications as their first through third line choice for treatment of dystonia in people with CP. So I would say the majority of people only use one of these 6 medications to treat dystonia and CP. And if we look at how they use them, now this is a bit of a busy table, but I think it's important to get this information out there. This is the typical dosing that people used at the bottom, starting dose and max dose. These are the things that they said were indications in the second row, the things they said may make them want to stay away from using this particular medication. And this is kind of the order that they chose to use these medications: first, second, third, or fourth line. And I'm not necessarily going to go through each of these boxes in detail, but I do think it's valuable to get this information out there to the community at large, both to make sure that your dosing is matching consensus dosing for these medications in people with dystonia with CP, and to make sure that if you yourself are experienced dystonia and have CP, that you know how far your doses can be pushed and how much room you have left to go if you feel like a medication is currently helpful, but you could use a little bit more help on that medication. I think knowledge is power, and having this knowledge to as many people as possible can be potentially helpful. Now, these are all doses and indications and contraindications as described by the physicians we surveyed. This is not inherently outcomes driven. This was not done, these doses were not validated in a clinical trial, but I will tell you, wouldn't it be great if it was? So something that we would all love to do as sort of a next step, now that we've established what's already being done in the community, is to see if we can use this data to build something further. Can we use this data to actually start comparing some of these medications head-to-head in a trial? And that's the future hope. That's something that we hope maybe the next time I speak to you all, I'll be able to talk to you about that. But this is a start, and this is where we are now. So when we think about comparing the effectiveness of current treatments, I think the biggest message is that we have a lot of room to go. There's a lot more that needs to be done. That's particularly true for medications that are enteral, so either taken by G-tube or by mouth. And there is some suggestion that maybe clonidine is getting underutilized as a dystonia treatment, with very loose data backing up that statement. But it is something to consider if you don't typically use it as a medical provider, or if you yourself haven't been on it but experience functionally limiting dystonia. Think about whether clonidine could be a medication option for you. And then the other thing that I want people to take away is that there is a lot of, a decent amount of data, or at least more data, supporting surgical interventions for dystonia and CP than even oral medications for dystonia and CP. So be aware of those options, intrathecal baclofen and deep brain stimulation. And if you feel like you have functionally limiting generalized dystonia and medications are just not cutting it for you, know that those options are out there and that you should have the chance to pursue them and see if you'd be a good candidate for them. So overall today, talked about the importance of where we start. You can't treat dystonia without diagnosing it. So something that we've really worked on a lot in our research is improving diagnosis and severity assessments. Then talked about really the importance of identifying triggers and setting functional goals. And then last talk about we talked about the room, the significant room we have left to start thinking about optimizing existing treatments for people with dystonia and CP. So with that, so many people to acknowledge, funding sources, and the innumerable people I have to thank. Not all of them could fit on a slider here. My contact information is below, and I look forward to taking your questions. Thank you.
I can tell that I might be having some, I'm going to have to find myself in my background is what's going to happen, because as you all know, I had an outage, so I didn't get to be able to fix this. You know what I'm going to do? Give me a second. I'm going to start asking you the questions, and then I will come up again. I'm going to change my system a little bit here.
Sure.
So I appreciate the presentation. So I just have to share that I always love listening to Bhooma because her knowledge is rich. And I was very excited when she said yes to being able to present today. But not only is her knowledge rich, and she's very humble in her knowledge, but she is a fun friend to hang out with. So I'm very excited to be able to share her with you.
Oh, well, thanks, Valerie.
I love you too. I might have gotten knocked off. Nope, I'm here. So I think we're good here. I can try to come back. Maybe. I don't know. We might not get my video. There I am. So we have a couple questions in the chat, but I want to encourage everybody to go on ahead and put, if you haven't already, to put them in. Some of my staff have been texting me in the background so for some questions as well too. So I have those other ones. But before we even go any further into all of this, I just want you to know we're going to go over at the end about your ability to be able to get your certificates for your CMEs and all of those sort of housekeeping things. So So let's go to the first question. This is Kate is asking us, she says, from an PT or an OT standpoint, are there interventions, which you've sort of talked to this, that have shown to improve function despite the dystonia and to reduce those overflow movements during functional activities? So you've spoken to this, but I think, especially since I'm an occupational therapist, are there any points maybe that you didn't have that are meaningful? Because these are tough cases and we want to be able to help those kids.
Yeah. I think, I mean, thank you for that. Thank you for that question, Kate. I think that the best data-driven therapy option we have is co-op. I think the other thing beyond that, I think conceptually, so co-op is a very sort of structured form of functional goal identification and then step-by-step ways to accomplish that. And I don't want to sound too naive because I'm not an occupational therapist, but I think the framework of that to me is very important. So that specific type of therapy I think is very valuable and is the best data-driven therapy to my knowledge that exists for dystonia and CP. But I think thinking about achieving a very defined functional goal for someone with dystonia and then thinking about achieving it incrementally is conceptually very important across all therapies. So I guess that's kind of the overarching message I would take from that, but co-op is the therapy that has the best data behind it. And I'm seeing her next question about levodopa as well. Mm-hmm. Yeah, so we have seen it for decreased dystonic movements. In the survey that I mentioned, people tended to use levodopa if they felt that someone's CP had an unknown cause or had a defined genetic cause. And if someone has, there are very specific kinds of CP that have been shown to in those people, if they have dystonia, that's been shown to respond best to levodopa. I will say at large, the study that we have on levodopa and CP showed overall little effect, but there may be subpopulations of people with dystonia for sure that respond to levodopa, and it's possible that there are subpopulations of people with CP that respond to levodopa as well. In my clinical practice, we tend to do a levodopa trial almost always before we pursue deep brain stimulation for someone. Usually just in the course of the workup for someone getting deep brain stimulation, we'll do the levodopa trial because it's, you know, kind of if someone has not tried that medication, we'll give it a shot, kind of the one last medication option that we want to make sure we check that box before we do surgery. And then the other situation in which I'll do it, and this is typically rare, is if you see on MRI that the pattern of brain injury is relatively restricted to the brainstem, where the substantia nigra is, the part of the brain that makes dopamine. So if you see that that part of the brain has been injured, often in those kids, I will try levodopa very early to treat their dystonia. But for kids that tend to have striatal injury, which is what we usually see in someone with term hypoxic ischemic encephalopathy, for example, then levodopa often will not be effective for dystonia treatment. Sorry, I'm like fighting a cough. I apologize.
Yeah, it's going around, isn't it? I do have a question. Bhooma, can you talk a little bit about deep brain stimulation and in relationship to dystonia? Because you just mentioned it, and then I'll go to the next questions.
Yeah, absolutely. So deep brain stimulation is a treatment that involves implantation of an electrode, and the only FDA-approved location now is in a part of the brain called the globus pallidus pars interna. And the idea behind it is that, and I mentioned sort of motor pathways and motor circuits earlier. So the idea of dystonia is that it's a circuit disorder, that there are multiple areas of the brain that are all interconnected that can, if any part of that circuit goes awry, that you can have that circuit just kind of trained to go into a dystonic pattern and give you dystonia. So the idea behind deep brain stimulation is that you're stimulating a part of the brain, not necessarily to excite it or inhibit it, but to break that circuit. And in some ways, you know, co-op is a different way to break that circuit. OT is a different way to break that circuit. You're retraining it step by step. Deep brain stimulation is, you know, a more invasive way to break that circuit. So that's the idea behind it. There is a lot of work going into what parts of the brain may be best to target to kind of break that dystonia circuit. But right now in kids, the GPIs are the only FDA-approved option. Because of that, the candidacy for DBS tends to be people who on brain MRI have limited, have you know, very little, if and ideally no injury to that part of the brain, the GPI, so that we think that there's a better chance that having electrodes put in there will be effective. And then there's also a general feel that people with generalized dystonia that is hyperkinetic, meaning there are some kids that have dystonia that don't move very much. And then whenever there's an attempt to move or whenever they are handled, they then become very dystonic, but most of the time they have low tone and aren't moving very much. So that's kind of one group of people with dystonia, of many different groups, but that's one, maybe one category. And then there's another group of people with dystonia where they're, you know, trying to move, but every time they try to move, their dystonia is, there's lots of movement. So we think of them as almost a hyperkinetic, lots of movement type of dystonia. And the thought is that it's the hyperkinetic dystonia that may respond best to DBS. So if you have someone with hyperkinetic dystonia and their brain MRI doesn't have injury to that part of the brain, they may be a good DBS candidate. All of that take with a grain of salt. We have, again, limited data to support that, but that is how we would select a DBS candidate at our institution.
Okay, that's fascinating. So Samantha asks us, does a child with significant dystonia in their upper extremity always grow up to be an adult with dystonia of significant severity? Like, is there a correlation?
Yeah, that's such a great question. Samantha, we don't know. But there are some hints. So I think many of us may have anecdotally heard about how someone with very limited dystonia or maybe even no dystonia in childhood ends up developing dystonia as they get older. And that I've heard stories of this. There are adults with CP that will tell you this. There's a case series that's done with Kara Graham's group in Australia where they tracked people with scoliosis over time. They tracked the same group of people with scoliosis in childhood and then in adulthood, and they showed, you know, somewhat serendipitously that the rate of dystonia increased, or the incidence of dystonia increased in that same group as they got older. Now, is that because their dystonia emerged or became more severe over time? Or is that because it's just easier to pick up on dystonia in an older person than it is in a younger person? That's hard. It's hard to know. But I will tell you, my gut is that dystonia tends to get more severe with age. That is kind of the general feeling that I get based on both this anecdote and loose sort of longitudinal studies. But I think that's such an important question that deserves dedicated study. And it is something that I think will be a hot topic of research. So your specific question, does a child with significant dystonia in their upper extremity always grow up to be an adult with dystonia of significant severity? I would say I don't know, but I would tend toward an answer of yes, that I think if you have dystonia in childhood, that you will continue to have dystonia in adulthood, and the dystonia may tend to get more severe with age. But the data for that is a data-free statement. So I will take that for what you will.
That's a great phrase, data-free statement.
It's a data-free statement.
But I think you're right.
Yeah, but that's my best guess. It really is.
Yeah, right. Okay, so this is a great one too. So I think Samantha also asked, because she's been noticing a decrease in upper extremity dystonic movements with hand braces or a thumb stay. So what is the role of like proprioception? Can it have a positive effect in function, decreasing the dystonia? And then, what about bracing and kinesiotaping for these children or individuals?
Awesome. So Samantha, if you're looking for a job, please call me. I think that's also a great question. There's a lot of good data on proprioceptive deficits in adults with idiopathic cervical dystonias. And you may or may not have heard of this concept called just antagonist, which is kind of this classic neurologic phenomenon in adults with idiopathic dystonia. So these are focal dystonias not associated with CP, where people with these focal dystonias have a tactile trick where they will touch the affected muscle, and that helps relax the dystonia. So I will tell you that particularly in our kids with hemiplegic CP that have dystonia in just one upper extremity, we will recommend compression sleeves to see if that proprioceptive input will help decrease their dystonia. And it's hit or miss, but for some people it does work really well. I do ask people, particularly with focal dystonias, if they feel like they know where that limb is in space, if they're like knocking it into things because their movements are out of control, because they really don't know where that limb is. And it is shocking how well young children understand that question, and families understand that question. So I do think that proprioception does play a role in dystonia, and that augmenting proprioceptive feedback can help.
Oh, so that's really fascinating, I think, because being the occupational therapist that I am, I just think of all sorts of ways that you could potentially, is it just, you have all sorts of options, not just bracing or kinesiotaping, just thinking about your interactions with the person instead of light touch. Is it firm touch? Is it, for a parent? So that's fascinating.
Yeah.
Okay, somebody's asking for your address again because the slide went too fast. So we're going to let Carrie grab that one for us. And then there's also a question about, is there any data on deaf children? I guess Mark might have to help us here. Is that related to deaf children and dystonia? I'm not sure about that one.
I think
that a correlation, Bhooma, that I just don't know about.
Not that I know of, but please do clarify. I'm happy to, my contact information is getting shared too, so feel free to reach out as well.
That might also work. Yeah, right. So I do have another question too. So a question, this was coming from my staff. So if you see that there's a lot of Valerie Pericinis, that's because of our outage, our staff had trouble logging in. So I pushed out my Zoom link.
Oh, that's awesome.
So I'm not omnipresent.
Well, wouldn't that be lovely, Valerie?
Got to make it work. That's all that matters. So she was asking, because they can't put it in the Q&A. When she observes children that are ambulating, if and they're looking at when they're looking at their ambulation, are those children? Actually, I'm struggling to read this because it's in a text. I think I guess when you're looking at a child, I'm going to summarize it in my own words. If you're looking at a child and they're ambulatory, and what is most important? What happens with their gait, or what happens with their upper extremities? What tells us most about the dystonia? And I'm going to get my earbud.
Yeah. I think it depends on the kid. So I think there are, I guess if I'm to think about how I would assess someone, for people that are maybe GMFCS1, GMFCS2, and you feel like their gait pattern is really, you know, pretty regular, pretty clear cut, that it's primarily affected by spasticity, make sure you also have them run, because then when they run, you might see that one arm come up. So for people that are, you know, GMFCS1 to, you know, are mild to, then I would say upper extremity during running may be the best clue to whether or not there's dystonia. And when we ask families about this, they'll say that too. Like when they're running, you'll see their arm come up, or you'll see them bring their arm to their chest. It's something that families notice very often. For people that are, you know, GMFCS 2 to 3, I think that the arms can be helpful, but particularly if they're a GMFCS 3 and they're using an assistive device, then it's really the legs during gait that are the most helpful. I think assessing gait for dystonia is very hard. I think it's really hard, and it's probably, although as a field, we probably have the most videos of gait overall, I think it's probably the hardest task to assess dystonia in, because there's so much happening. Like gait is such a complex movement. I think that hand open close task is honestly very helpful. It really does simplify the assessment quite a bit, I think.
I found it, and this was a discussion amongst our staff, so I'm going to say that it's probably one of their questions if they wouldn't ask it already, but I saw that you used the word, oh, here she asked it. Okay, never mind. It's the last question here. You used the term overflow. Another term used in therapy is fixing. Would you say this fixing is actually dystonia? This was our huge discussion.
Yeah.
The other day.
Okay, so maybe I guess. So I have. This is interesting. I love that. I love when, you know, the wild ideas I have are validated in Q&As for talks. So I was having this discussion with Wade Schrader and Teresa Moulton, and you guys probably may or may not know them, but they're wonderful medical providers who care for people with CP. And I was talking, and Teresa is a therapist, and Wade's an orthopedic surgeon. And I was talking to them about how I think we're all, I mean, what do we do as medical providers? We look at people as they move and we try to help optimize their motor function, right? And I think we all see dystonia, and I don't think it's actually, I think we all call it different things. I think that we are all probably seeing the same movement and identifying it, but calling it something completely different. And I think that that is probably one of the things that make dystonia so confusing. It's not, in part, it is hard to diagnose, it is hard to pick up on, but also in part, I think we all have just kind of developed our own terminology for it, and it's hard to talk about it, particularly in CP, in a way that we all understand what it is, because there's so many different providers involved and different specialties involved in caring for this population. So, Wade and I are actually working on a study to see if we can analyze how different providers from different specialties describe the same videos, to see if there's some sort of shared language that we all have. And so I don't know, maybe fixing is overflow. I guess I'll let you know. I'll let you know when we all look at these videos together. And I'm sure there are some things that only PTs say that I would call overflow, and that a PT would not call overflow. But if I were to tell a PT overflow, they would be like, oh, you mean fixing. I'm sure there's something like that, but I guess I would say to be continued on that question.
Yeah, it sort of speaks to the need for shared terminology, right?
Yeah.
Like to be able to develop that. And yeah, okay, yeah, absolutely. Well, we're actually coming up to the sort of towards the end of our time. And I want to make sure we get the, wrap it up. If Carrie, if you want to throw up the slide. Bhooma, thank you. Thank you. It was amazing.
Thanks for having me.
That's great. So I just want everybody to know that's on today that you will be receiving a follow-up email, and it will include a survey about today's presentation. You will also, if you're eligible for CMEs, you'll receive a certificate. So And just let you know, if you, for some reason, do not get any of this, you will see an email below at research@ucp.org. Reach out, make sure that we haven't, there was no oversight on our part. Also know that the link to the recording of today's presentation and actually any other ones, because we've had some really phenomenal ones this year, that they can be found on UCP National's website. You can see it there on the slide, but when you get on there, it's not always super findable. You have to click on that research tab, excuse me, at the top, and it will drop down and you'll see professional learning series. But please, please, please give us those surveys. Let us know. It helps us shape what we do. And when it, and as that, that leads up to the idea that we do have a series that's rolling out for 2024. We're putting some tweaks on the final pieces of information. But we do have some great things on constraint-induced movement therapy and hip surveillance. So please just keep your eyes out. The information will be coming soon. And then, of course, if you have any questions other than unrelated to your CMEs, you can still go back to research@ucp.org and get those questions answered. So I thank you, everybody. I know it's the Christmas holiday, and it's, Bhooma, I know that you're up on the holidays yourself too, because Bhooma's a mother of 3 children. So this was a lot, to add to your holidays, but thank you, everyone. It's been a great evening. So have a good one. Take care.
Thanks so much, Valerie. Thank you,
All right.
guys. Bye.
Bye.